everyone, my name is Diana Youssef. I'm a technical advisor at the Global Institute for Disease Elimination, GLIDE, based in Abu Dhabi. And I would like to welcome you to another episode of Elimination Exchange, a podcast series hosted by GLIDE that explores topics related to disease elimination efforts, specifically infectious disease elimination. In this podcast, we explore the significant strides made in the malaria elimination within the Middle East and North Africa region, the Mena Region, and its impact on the global fight against malaria. Understanding the past diversity and complexities of the malaria recession in the Mena region can provide valuable insights into the anticipated transitions over the next 3 decades in high-burden countries. During this podcast, we will discuss our collaborative work with WHO EMRO to understand the region's historical malaria patterns and the strategies needed to prevent its reintroduction. The project is with WHO EMRO, but we are pleased to have Professor Bob Snow on this podcast, who is providing technical support to the project. As such, the discussion in this podcast will reflect Bob's views and not any official WHO position. Professor Bob Snow is a professor of malaria epidemiology at the Center for Tropical Medicine and Global Health at the University of Oxford and principal scientist at the Kenyan Medical Research Institute Wellcome Trust Collaborative Program in Nairobi, Kenya. Bob has worked in Africa for over 40 years. Bob, welcome and thank you for joining me today.
Thanks, Diana. Yeah, a pleasure to be here.
So Bob, as you know, the Mena region has witnessed a dramatic malaria recession over the last 6 decades. During the 1960s and 70s, the last cases of malaria were declared in countries such as Tunisia, Libya, Palestine, Jordan, Lebanon, Bahrain and Qatar. And over the last 20 years, Morocco, Algeria, Egypt, Syria, Iraq, the UAE and Oman have witnessed their last cases of locally acquired malaria isolated within unique transmission foci. And the UAE and Morocco were WHO certified malaria-free in 2007 and 2010 respectively, and only the most southwestern tip of the Kingdom of Saudi Arabia and Yemen, with the exception of Socotra Island, harbor ongoing local transmission of malaria. Bob, my question to you is, and I think that our audience would be interested to know, why is this region of interest for a malariologist like yourself?
Yeah, I think that's a good place to start, actually. It is a fascinating part of the world. Huge climatic events that have all shaped what the Mena region currently looks like. And it's, huge diversity from large rivers like the Tigris and Euphrates, the Nile, massive mountain ranges, salt pans, oases, marshlands. It's an incredibly diverse geographic area. And that diversity has shaped the types of malaria mosquitoes that you see across the region. It's probably also worth mentioning that people over time in history have settled according to where there is water. So you have this congruence of different mosquitoes, human settlement occurring across the region. And we're quite fortunate in this region in that, we have historical documented evidence of the impact of malaria going as far back as the early writings of the Sumerians. And of course, ancient DNA from mummified remains in Egypt showing the presence of Plasmodium falciparum and Plasmodium vivax. And also the evidence that it must have had a pretty big burden even in ancient times, because you can identify sickle cell trait, which is an anomaly of the human hemoglobin, but is protective against malaria. So there is evidence that, it did pose a selective force on the human genome going back to Egyptian times. I think the other thing that's probably worth mentioning at this stage, because we'll come back to it hopefully in the podcast, is that the region is quite connected. I think people tend to think of sub-Saharan Africa, North Africa, Middle East as being quite independent entities over time, with very distinct populations and things. But they were in fact connected. You have evidence of Phoenicians moving to Tunisia. There's sort of 13th century trade across the Sahara, huge numbers of people being moving across the Sahara for gold trade, salt trade, and unfortunately slave trade as well in the 13th century. There's also the connection between the Sultanate of Oman and East Africa, where there were sultanates in Zanzibar, and all these areas have been connected quite intimately over time. So there's this huge connection of people across the entire region. I think all of this just makes it, massively interesting. You have to sort of bring together genetics, history, geography, to really understand the current epidemiology of malaria, or the epidemiology of malaria elimination in the region.
Bob, thank you so much for setting the scene for our listeners. And you're right, it is really super interesting. And as I mentioned at the beginning of the podcast, the Mena region has made great progress towards the elimination of malaria. And can you elaborate on how this was achieved? So give us a little bit of history.
Yeah, sure. I think each individual country in the Mena region has had its own history, its own challenges, and its own trajectory. I don't think we've got time in the podcast to go through each individual country. I think what would be important, perhaps for your listeners, is to have sort of a broad outline of the sort of phases of malaria control in the Mena region. And this kind of begins around about the turn. I mean, it's not to say that the ancients didn't have their own ways of dealing with what was called malaria, or was felt to be malaria, but if you look at the sort of more recent times, documented evidence of actual control, it starts at the beginning of the last century. A lot of the control was to protect European interests in the region and economic interests in the region. And a lot of that was focused on things like larval control and environmental management. I mean, one of the sort of classic documents is by Sir Ronald Ross, who's the man who unraveled the role of mosquitoes in human malaria transmission, when he visited Suez and instigated a whole lot of environmental management to control mosquito populations in the Suez in about 1904. And that was pretty typical of the whole region, actually. There was a lot of environmental management, larval control going on all the way up to the beginning of the Second World War. And, there was also some interesting reconnaissance done during the First World War, when I think Allies realized there was an additional foe in malaria, and they had to sort of map out where mosquitoes were, set up mosquito brigades to protect troops and so on. And at the Second World War, that was carried on. There was a lot more reconnaissance done, survey work done, but of course then you had additional tools in the toolkit like chloroquine and DDT, so they were increasingly used. So that's kind of like the first 50 years, if you like, of the last century. I think the biggest push and the most sort of important period was from about the mid-50s through the 1960s, and this was led by WHO in partnership with countries and also with a lot of support from UNICEF and USAID and other sort of donor agencies. At that period, malaria had transformed, the geographic distribution of malaria, and it as a public health burden had transformed from being sort of a major problem to something very focal and very localized. And then there was a period where I think you have two competing things going on. There was a period of massive economic expansion and urbanization. And this was at a time, from the 70s through to the 90s, when I kind of get a sense that, the global community had taken its eye off the malaria ball. But in the Middle East, certainly, there was rapid economic development, transforming the landscapes from rural ones to urban ones. And I think this impacted quite significantly on the malaria landscape independent of any control. So you have that one factor. And then almost on the opposite side is that during that period, from sort of 80s through to the 90s, you had a growing drug resistance problem. Drugs began to fail. Huge migration of peoples into the Middle East for work in economic activities. And of course, climate change again. The El Nino appeared, and you had this perfect storm where in areas where malaria had not been eliminated, it came back with a bit of a vengeance. And I guess the last phase began in about 2000, again led by WHO and countries, where I think they began to see that the last mile could be achieved. So, as you said in your introduction, this was a time when elimination was actually achieved, and there was a lot of sort of geographical reconnaissance going on, finding the last cases, eliminating it, to the point where, you had, malaria was actually no longer transmitted in large parts of North Africa, almost all of North Africa, and large parts of the Arabian Peninsula, with the exception, as you point out, of the southwest of Yemen and a very, very small part of the Kingdom of Saudi Arabia.
Thank you so much, Bob, for providing some of the history. I think it's really important to understand sort of, where we've come from and where we're going. Which brings me on to my next question on what we're currently doing together, GLIDE and WHO, on this collaborative project for which you're a strong technical support, and of course in collaboration with countries in the MENA region. This project really involves, or the aim of the project is to really better understand the receptive risks for the possible reintroduction of malaria across the region. So Bob, regarding the current project, can you explain what this involves and why it's important?
The timing of this project is a good one. It's good that GLIDE have supported WHO and working in partnership with WHO to do this right now, because the WHO Global Malaria Program in Geneva are currently revising their guidelines on the prevention of reintroduction of malaria. And the concepts of receptivity and vulnerability kind of drive the sorts of information that we want to build up under the project. It's like, where are mosquitoes located? Where are the maximal extents of transmission that could occur? And what was the, likely pre-control, pre-intervention diversity of transmission within a country? The first thing, of course, to bear in mind, and going back to sort of the geographical distribution that we discussed at the beginning, is that there are large areas of the Mena region that simply cannot support malaria transmission. This has been known for some time. Deserts, high altitude areas, and sort of salt pans, they're simply unable to support mosquito populations. I want to go back to what the malariologists did in the 1950s. They used to draw these hand-drawn maps and get a box of crayons out and colour things in. And we tend to dismiss that. But we actually use it in this project because it was based, although it's not sophisticated satellite data, actually what did sort of represent decades worth of experience of malaria in each of these individual countries, and it shouldn't be ignored. So I just wanted to call out the huge effort that was done, and with great sophistication, but often with a box of pencils. So moving on to the second piece is, where are malaria mosquitoes located? And this is a huge part of the project. It's digging back through archive material, archives that are held in Paris, London, Geneva, Cairo, many other areas, where we were able to find original reports from colonial authorities, consultants' trip reports, peer-reviewed literature, which we also search in a traditional way using systematic review approaches, and build up a sort of archive of material that has described where mosquitoes have been identified. And then we put in the species, longitude and latitude that we get separately using different GIS platforms. That's Geographic Information Systems platforms. The types of mosquitoes that were, whether they are adults, larvae, the types of survey that were done, whether it was dipping for larvae, indoor catches, outdoor catches, and the ways in which the malariologists identified the mosquito populations, whether morphologically or more recently using PCR. So that then gives us a huge database of where we have seen mosquitoes that probably still exist to this day and serve as a receptive ecological niche for malaria. Now, obviously, the third part is within that, before elimination, and here we're only interested in historical data. The malariologists did these big surveys that I described previously, and they went from village to village, examining children and adults for whether or not they had malaria in their blood, which we call the parasite prevalence, or they had enlarged spleens, which is a proxy for infection or chronic infection. And they documented all this data in very old reports, and we extract that in the same way as we do vectors by giving each survey location a longitude and a latitude, how many people were examined and how many were positive. And as I say, this gives us some sense of the historical diversity of malaria within each country.
Bob, you mentioned the importance of understanding the prevention of reintroduction of malaria. From this current project with WHO EMRO and in collaboration with countries in the Mena Region, what can we learn from this project beyond malaria elimination?
Yeah, I mean, that's a really good point, actually, because I think the concepts behind the prevention of reintroduction apply to all vector-borne diseases. To a large extent, vectors don't go away, but the disease does. And you need to really understand how receptive an area is for the reintroduction. I mean, we all know that things have an uncanny tendency to reappear over time. So understanding that is really key. So even when the disease ends, disease mapping should never end, and disease surveillance should never end. So I think that's a general point that speaks to all diseases that have been eliminated or under the process of being eliminated.
Thank you so much, Bob. And if I can just invite you to provide sort of, one or two key takeaways for our global audience working in infectious disease elimination before we close our discussion.
Well, first of all, it's a fascinating area to be involved in the present day. Infectious diseases haven't gone away. They continue to plague the planet. Understanding geography, history, genetics, the biology of the mosquitoes or the vectors that you're dealing with is absolutely key. And yeah, I mean, if anyone were thinking of starting a new career, this would be one I would strongly recommend.
Bob, thank you so much for your time and your very valuable insights. It's been a pleasure having you on our podcast.
No, it's been my pleasure, actually. Thanks for having me, Diana.